Today I'll discuss kind of the interface between when a patient has a radiculopathy that presents with peripheral numbness or tingling or weakness and deciding whether or not the lesion is still active in the spine that's creating those symptoms or they're actually residual. The insult to the nerve was so great that there was some damage, and now even if the spine has healed and the nerve has healed, there is residual weakness or peripheral neuropathy in terms of paresthesia. So let's take an example of a neck derangement that responds to retraction extension, and the patient presents with, let's say, wrist extension weakness. Now, we probably will see if this person is a responder to retraction extension that all signs and symptoms are improving, including wrist extension, resisted wrist extension. But let's say we get to the point where the patient's like, I feel great, and their neck range of motion has normalized, their nerve tension has normalized, but that wrist extension is still weak. So there's a chance in that getting to that process in the preceding days or weeks, we're really curious whether or not there was still some affected problem or a problem in the neck, but now it seems like the neck has healed and this is residual. How would I distinguish the two? For me, if that patient is a retraction extension responder, that's what they responded to over the course of, say, 6 or 7 visits, their radiculopathy healed, well then I would want to test what happens when we perform neck flexion. I would start by testing neck flexion in the clinic, of course, and if the patient can do 30 or 40 without any repercussions negatively, then it would become part of the home program with also some extension just for prophylaxis. But in the clinic, it would look like doing this and retesting that wrist extension to see if it gets worse. In this case, I would be using a repeated movement to test the integrity of the healing and to look for a worsening presentation. I'm not expecting wrist extension to get better in that case. I'm just trying to make sure it doesn't get worse. So if we do some neck flexion and neck range of motion stays good, nerve extensibility stays good, other upper extremity or neck complaints, signs or symptoms stay good, but that wrist extension still stays weak, then it would be an indication that there's no longer an active lesion in the spine, and wrist extension strengthening with a TheraBand, with weight, whatever, is appropriate to get that strength back, that strength that was lost with that more aggressive nerve irritation, impingement, pinching, whatever you want to call it, in the nerve that controls wrist extension. If we talk about an example with neuropathy or paresthesia, let's talk about peripheral tingling in the foot. If that is related to a radiculopathy in the lower lumbar spine, and say that that person needs side glide to resolve it 80% of the way and then some lumbar extension to resolve it the rest of the way, and just like in the above example, lumbar range of motion becomes normal, there's no nerve tension in the lower extremity, all other signs and symptoms in the lower extremity and back have resolved, but there's still that patch of numbness and or tingling, we would likely do lumbar flexion to again test the integrity of the lumbar spine and the nerves, the nerve roots coming out of the lumbar spine, to see if there's still an active problem in the spine. Same as with the upper extremity example I gave, we would do lumbar flexion in the clinic if we're not noticing that there's an immediate worsening of numbness and tingling, which I would not expect that change to be as abrupt as, for example, strength or nerve tension. I don't expect a patch of numbness and or tingling that's been there for weeks to months to change in minutes. But we're just going to make sure it doesn't get worse, or we don't lose lumbar range of motion, we don't create nerve tension on the sciatic nerve. If we can do 20, 30, 40 in the clinic and not see any negative repercussions, that will be something that we will add to the home program over time. In the case of strengthening, we can add some strengthening, or in the case of weakness, we can add strengthening, of course, like in the example of the wrist extension. Commonly we see that with triceps extension, at least commonly I do, that the triceps stays residually weak, and that needs to be addressed with a strengthening regimen. With the numbness and tingling, it's more about education. There's not going to be a movement that you can do to restore that numbness or tingling. It's more about education about what is damage to a nerve, how long would we anticipate it to take for it to repair. Things closer to the spine, that nerve regeneration doesn't have to travel as far. So very distal problems like the foot can take pronounced periods of time, months to years, for that healing to occur. But part of the education for the particular patient in that scenario is that, look, your problem has healed. You can flex, you can extend, you have full nerve extensibility, for full lumbar range of motion, etc. You just have this problem from when the nerve was really irritated and it became damaged in this part of the nerve that controls sensation in this part of the foot. And so you want to take the patient and tell them this is probably going to repair. There's nothing we're going to actively do except for create an environment for healing. So an environment for healing would be keep your full lumbar range of motion so that there's no possibility that you are putting some stress on that nerve. Possibly we could add some nerve glides to make sure that the nerve is still moving well on a sporadic basis, but that's typically not part of what I'm doing. It's more about, this is a problem that's already happened. You need to be fully aware that you can start being an active, athlete or whatever it is, and not worry about this little patch of numbness and tingling. For example, this is not something you would have surgery for. This is just how the damage happened. We can move forward and not necessarily have a lot of therapy visits, just knowing that this will take time. Likely it will heal, but it will take time if you create an environment for healing. So that kind of interface is how change from these stages in therapy. That's how I approach them in terms of strengthening and numbness and tingling. It's just one way that I can be sure that the lesion has actually healed is by stressing the lesion in the direction opposite of the healing direction. So if the healing direction is extension, I'm likely looking at flexion. Very rarely would I contemplate kind of doing side glide to the opposite direction or rotation to the opposite direction. Typically flexion is what I'll use because that provides a lot of stress through the lumbar spine and the neck if you do it repeatedly. I mean, extension is a stress as well, of course, but flexion is more of a stress where there's a potential for posterior migration and irritation to the nerves. So that's how I deal with those two scenarios.